Hi, this is Dr. Stephen Allison, and we're busy with a whole series of videos on ophthalmology made easy. Today's video is really interesting because we are going to use what the patient tells us as a tool for diagnosis. Remember that vision is a subjective thing. You can't tell a patient what he sees. He has to tell you what he sees. So before you do objective testing, let him tell you subjectively what exactly he sees, because that will tell you a massive amount and get you really close to a diagnosis before you've even looked at the patient's eye. So let's dive straight in. One of the more common things that people complain of, especially over the age of 50, are floaters. These are things that float around in the eye. Suddenly there's these things floating around in the eye, and it really makes the patient worried. When they look this way, this things sort of follow the vision that way, and when he looks this way, they follow that way, and sometimes they're there, sometimes they're not there, really worried that they're going to go blind. So floaters are very important because it's normally a PVD, posterior vitreous detachment. Now, what makes the diagnosis of posterior vitreous detachment very, very important is that one must go and have a look if there has been damage caused by the vitreous when it pulls away. So how it happens is, vitreous is jelly in the eye. It's the jelly in the eye, massive jelly that's hard, like jelly that comes out of the fridge when you're young. When you grow older, the jelly in the core of the vitreous of the jelly becomes like water. It becomes senolytic. So you get more and more water, and the core becomes more and more like water, and you've got this tiny little crust of jelly on the outside, and eventually that jelly becomes too heavy and pulls away and implodes into the central part, the central core that is now water. And that pulling away action is called a posterior vitreous detachment. Then some debris can be floating around in the water, and these are the floaters that you see. That's what they're called, floaters. They float around in the water. That used to be jelly. Now, it's very important to listen to the patient, because they give you a clue as to whether this is a PVD or not, because the story is very, very typical. They say they saw these flashes in the distance. They saw these flashes in the distance, like lightning flashes, and they're sometimes colored flashes. And then for about a week, and then they were gone. And then when those flashes were gone, suddenly they saw these things floating around in their visual field. That's a very typical story of a PVD. Now, it's just important to remember that with the pulling away action of that vitreous, four things can happen. One, it can just pull away and be no problem and just create floaters. Two, it can open up a little blood vessel when it pulls away and give you a bleed. That normally the patient would complain of a spiderweb, cobwebby sort of look and an amber hue to his vision. That means there's red blood cells floating around in his vitreous. Thirdly, it can make a small hole in the retina, which the patient doesn't see at all because it's in the periphery. And that can allow some of this senolytic vitreous to get in there and push off the retina and create a retinal detachment. Or the vitreous, when it does pull off, can pull off the retina immediately and precipitate a retinal detachment. So what is going on here? When he does have a retinal detachment, the sign is that his vision is normal. He had these flashes, he maybe had a bit of floaters, and suddenly there is this dark cloud infranasally. This dark cloud that is just absolutely no vision. He's got normal vision and this dark cloud. This cloud could be anywhere. It could be in any of the quadrants, but the most common one is infranasally. So that's a sign of retinal detachment. So we've got the flashes, we've got the floaters, we've got the retinal detachment. Excuse me. How does this little lot happen? Why does the patient see these flashes? How that works is that the retina basically has no other receptors other than visual receptors. So if you touch a retina, it says to the brain, I'm seeing. If you pull on a retina, it says, I'm seeing. So what happens is the vitreous starts wiggling to pull away, and that wiggling action and the pulling away action stimulates the retina, and that's why you get the flashes. Once it's pulled away, the flashes stop because it's not touching the retina anymore. And then you get the floaters. If there's a retinal detachment, you get the dark cloud, this black cloud that that impedes your vision, but the rest of the vision is normal. So there's this irregular scotoma, peripheral scotoma, infrally, any of the quadrants, or even majorly so, but that there is this irregular black cloud is retinal detachment. If you have any of these symptoms, the patient needs to get to an ophthalmologist, needs to be dilated, needs to check. Is there a retinal detachment? Is there a bleed? Is there a hole in the retina that needs laser therapy, or does he need formal surgery, or does he need nothing at all? So, and just reassurance that he'll be fine. Right, then the next thing that we get onto is a massive topic, is cataract. Now, what is a cataract? Basically, excuse me, the lens inside the eye is a bag of jelly. What an amazing thing. There's a bag of jelly that is attached to a cylindrical muscle, the ciliary muscle, and when the muscle contracts, the bag is released and becomes fatter and becomes more plus and refracts the light or bends the light more. And when the lens is flatter, it bends the light less. So it's basically an autofocus. Can you imagine an autofocus mechanism built into your eye that keeps you in focus for distance, for near? You need 2.5 diopters of accommodation to stay in focus, and it does that for you absolutely automatically. Incredible system. The problem with that system is that between the ages of 45 and 55, it stops working, and it sort of flattens out. That's called presbyopia. It happens to absolutely everybody, and your arms become shorter and shorter. As you can't see, you can't focus to the near objects. So what you need is what the lens did inside your eye, you now need from the outside. So you buy yourself a pair of spectacles to read, get the spectacles, you go to an optometrist, get spectacles, and you bring yourself into focus. In other words, you do what the lens did for you automatically, you have to now do from the outside. That's called presbyopia. It happens sort of in the midlife time. Now, if we go further, some patients are very often it's just for no reason at all. Some of those lens proteins coagulate. They start coagulating, and when they do that, they go white. It's a bit like the white of an egg that you throw in a pan. You throw it in the pan, initially you can see through it, and as it coagulates from the heat, it goes white, and the more it coagulates, the whiter it gets. So in a lens, the more it coagulates, the whiter it gets, and the less you can see through it. Now, coagulated lens proteins that have gone white, that are in the way and impeding vision, are cataracts. That's what a cataract is coagulated lens proteins that's white, that's in the way. So what will the patient complain of here? The patient comes in and says, I was fine till a year ago, and then everything just started becoming misty. It's a mistiness. It's as though I need to clean my glasses all the time. It's as though I'm looking through frosted glass. It's as though there's a mist over everything. The important part here is that there is no scotoma. In other words, there's no black cloud. There's no floater. There's no specific thing. It's a generalized mistiness. That's a cataract. Okay, what are the causes of cataracts? Very often people ask, wow, what happened? The causes of cataract, the most important one is age. It's just a wear and tear disease. It's part of growing older, unfortunately. That's most of them. And then a small list of diabetes, trauma, chronic inflammatory causes. There can even be congenital cataracts. You can even be born with cataracts, measles and that sort of thing. So, but those are rare. The most important thing is more senile cataracts, which means age-related cataracts. The good news is that's one of the really bad visual impairment diseases that we can remove. We can go in, open up that little bag, remove all that coagulated muck, throw it away, put a plastic lens in its place, and restore the vision. What an absolute pleasure. So cataract can be treated really, really effectively. It's the most cost-effective operation almost that there is for what you get, from no vision to good vision within 24 hours, and the patient is cured for life. So that's cataract, huh? Misty vision, but no scotoma. Let's go on to scotomas. Scotomas can be divided into two major groups: central scotoma and peripheral scotomas. Now let's go on to central scotoma for a moment. This is normally an elderly patient, Caucasians especially, over the age of 70, 75, somewhere around there. They say that suddenly they cannot see in the middle. The central part of their vision is black. So everything else is okay. They can see past this black dot in the middle, but there's this black dot in the middle, and as luck would have it, that's right in the middle, there where you're supposed to read, there where you're supposed to look. It's just not fair. So they have a central scotoma, and the rest is okay. You see them looking at their watch like this. They look over there to see there. So you look onto your peripheral vision rather than onto your central vision, because if they look directly at their watch, they can't see the central part. Now that is very typically age-related macular degeneration. Age-related macular degeneration, what a devastating situation, because what is dead is dead. You cannot bring it back. How macular degeneration works, it's an oxidative, vision is an oxidative process, and there's always buildup of byproducts. Now these byproducts build up in the retina. They do get scavenged away over your life, but when the scavenging effect of the byproducts of vision starts building up in the back of your eye, they collect at the macula and damage the macula. Now there's two types of macular degeneration. There's a wet and there's a dry. The wet type of macular degeneration is where new vessels form and create a bit of swelling or edema around the macula. For that, we can give injections to the back of the eye, anti-VEGF, anti-vascular endothelial growth factor injections. We'll speak about that at length when we speak about diabetes. But we have injections that we can give. The bad news is it's only about 10 to 20% of cases are wet AMD. The rest are dry AMD. It's an atrophic AMD, and there's precious little we can do about that. So the important thing, that the important take-home message here is that if you have a family member that has got AMD, or if there's a family history of AMD, be very careful to live a clean life. Get the antioxidants going, get the omega-3 going, don't smoke, alcohol to a minimum. You've got to live a clean life, or central scotoma is what's waiting for you. So that is a central scotoma, AMD. There are little things like branch vein occlusions and central retinal vein occlusions that also appear like this. That is a vascular problem. It's like a small stroke in the eye. For that, we can also give those injections to prevent new vessels, and of course anticoagulations that you can drink. So those are central scotomas. So the patient, what do they complain of? Everything's fine except in the middle there is this black dot. Now you know the other central scotoma or semi-central scotoma that we spoke about was retinal detachment, but very typically retinal detachment is not in the center. It's always in the side. Okay, it can encroach on the center, but there is a massive scotoma coming in from the side. Okay, so that is the difference between the two. That the central scotoma is AMD, the peripheral scotoma, segmental, is normally a retinal detachment, and now we get onto a terrible disease that creates a peripheral vision loss, sort of all the way around. It starts in bits, but eventually it eats away the peripheral vision, and it's like a thief in the night. It is not a painful disease. It's very often not painful. It's sometimes painful, but very often not painful, and it steals your peripheral vision, so the patient almost never complains of his visual defect. That disease is glaucoma, high pressure in the eye. In this case, they would complain maybe of bumping into things, or that they, when he's trying to pass a car, he doesn't see the car so nicely on the sides. But it's very often just a thing that you pick up coincidentally, the high pressure in the eye. But glaucoma specifically doesn't take away the central vision, it takes away the peripheral vision, and it eats away at it, and it eats away at it, and it eats away at it. And by the time he complains of visual loss, it's almost too late, because what is gone is gone. So it's come in, so much so that it starts encroaching on his central vision. You've got real trouble. So what is the take-home message with glaucoma is family history. If there's a family history, you must have your pressures checked, because our treatment cannot bring back vision, but it can halt the process. It can stop it in its tracks. So if it's eaten away your vision up to here, and we put you on therapy, or we give you a surgery that stops the high pressure, it can stop the eating away of your vision in its tracks, and you can keep your central vision. So that's the good news, is the central vision is spared to a large extent if we can catch it early. Right, so that's big diseases that we spoke about. Now, I think we need to talk a little bit about, I won't do it extensively, but we must talk about refractive errors. Refractive errors also present in very interesting ways, and they normally present in children. So it's very important, if children come with visual problems, to listen to their story. Now, just how it works, let's just get a picture in your head that here's an eye, here's the front of the eye, here's the cornea and the lens and the iris, and here's the retina at the back, and here's the optic nerve. You can imagine that. Now, when you're born, or when you're very young, the front part, the cornea and the lens and so on, are almost adult when you're born. That's why babies always appear to have big eyes, because the front of their eye is actually already adult size. The part that grows is the retina, is the back of the eye. So the back of the eye grows. It starts flat, and it starts growing and grow and grow. As the face develops, the eye grows with it and grows with it, and sort of between 6 and 12 years of age, it gets to what we call the null point, or the absolutely round. So when the eye is absolutely round, in other words, the front and the back form a good sphere, then the eye is perfectly in focus, and your accommodative reflex, your lens, keeps everything in focus, and all is well. So that's a normal process. What happens, though, in a certain percentage, is that the eye doesn't get there. It grows and grows and grows, and before it gets to the null point, before it gets to perfectly round, it stops growing, or it slows down. Now, when that happens, these patients are what we call hypermetropic, or farsighted. Why are they farsighted? Because they need a plus lens in front of their eye. A plus lens, in other words, to bend the light a little bit more than they're bending at the moment, to bring it to perfect focus on this retina that's a little bit in front of where it should be. Now, rather than put a plus lens in front of the patient, there is a plus lens inside the eye, the normal lens. That's already a plus lens. So what happens is the patient actually automatically compensates for the fact that they've got this flat eye. So in that compensatory mechanism is some positives for the patient. In other words, A, he can stay in focus even though his eye is not at the right level, but B, because it's a plus lens, it actually makes the image slightly bigger. So they've got a slightly bigger in-focus picture when they're hypermetropic, when they're a +1 or a +1.5. The eye's a little bit flat. And these are what we call farsighted. They can see absolutely fantastically when they're young. All right. The problem with them is when they get to the age of 45 and presbyopia kicks in other words, the autofocus starts switching off, they are very unhappy chappies, because that's the time they start saying, A, I can't see near. And when you give them glasses to see near, eventually they can't even see far. And now we have to give them bifocals and multifocals, and they are very difficult and very unhappy patients, because they're in denial, because they are used to being people that can see extremely well, in fact, a little bit better than everybody else. So hypermetropes, the far-sighted people, they have no problems until they get to 45. When they get to 45, they're the first ones that can't, that the arms get short and they need a bit of help from here. And they are also very unhappy with their distance spectacles, especially if you start putting multifocals and bifocals. They really struggle to handle those things, and they just need to be explained what's happening there with them. All right. The other problem with hypermetropia is if it's more than a 1 or 2, if it's maybe a 3, in other words, the eye is very flat. What happens, the lens accommodates, the lens pushes and to keep him in focus. But once the lens does that, remember we spoke about the triad that happens with a near reflex when we were doing the Argyle-Robinson pupil, is that when your eye accommodates, two other things happen. It not only accommodates, it converges, and you get meiosis. You get meiosis, convergence, and accommodation. That's a triad that's attached to one another. You can't switch one off and have only the other one work. So when the child starts seeing and they can see in the distance and they need to get it into focus, they sort of push into focus. Once that happens, the eyes pull in because that triad kicks in. So they're in focus, but in goes the eyes. Okay, so a strabism that develops, that's not from birth, that's a little bit further on, that the child starts seeing in the distance and the eyes pull in. It's very important to check that they're not maybe hypermetropic. So in other words, the treatment there would be give them glasses, give them what they need from the outside, give them the 2.5 or the 3 from the outside. If they wear their glasses, their eyes will be straight because their accommodation reflex doesn't kick in. You understand that? So in other words, but the problem with these children, they need to be motivated because they can see without their glasses. They have these horrible glasses that you've given them now, and it makes them see no better because their eye was doing it anyway for them. The only thing that you want as a parent is you want them to wear their glasses so their eyes are straight. But they don't care, they can see. So it's important to motivate those parents, to motivate their children to say that they must wear their spectacles. But if they're a difficult bunch because they don't like wearing their spectacles because they don't see much better. That brings us on to the next list, the next group, which is a very interesting group, are the ones that went too far. So now we were those that didn't get there, the hypermetropes. Then they go to the null point. That's the biggest group of the lot. That's the guys that don't need glasses. And then you get the guys that it went too far, a little bit too far, and more and more and more. And those are what we call nearsighted. They are the nearsighted people. They can see here, but they can't see there. Because their eye is long, they need a negative lens. So they have a minus error. Minus not because it's bad, minus because it's a minus lens. It's a biconcave lens, not a biconvex lens, a biconcave lens that you need. You need to bend the light open a little bit to then go through the mechanism of the eye and come to a perfect focus on this retina that's now a little bit further than it should be. The retina is a little bit further than it should be, so we must open up the light beam that hits the eye a little bit so that the front mechanism brings it into focus on this distant retina. The problem with putting a minus lens in front of someone's eye is that it makes the image slightly smaller. So it'll make the image slightly smaller, but at least it's perfectly in focus. All right, so the myopes. Now, when do myopes manifest? Hypermetropes, minor hypermetropes, they manifest either as children in the form of strabs or as adults when they become presbyopic. What do the myopes do? The myopes, in other words, the nearsighted group, the ones that the retina grew too far, they present at about puberty, somewhere around 10, 12, 13 years old. They start complaining that they can't see on the board. They have to move closer and closer to see on the board at school. So they play sport. They're not playing sport very well because they just, especially when there's low light, they just can't see so well. And those are the ones that are normally nearsighted because their eye grew and grew and grew to the null point, which was fine for a while, but now it's overshooting the mark and it's going a little bit further, and they need minus lenses to keep them in focus. Now these kids love their glasses because they can see. So without them they can't see, with them they can see. So those kids, you give them you give them their spectacle correction. Doesn't matter what those glasses look like, even if they're not cool, even if their friends give them a hard time, they'll wear them because they can see. What an absolute pleasure. You've taken a kid that can't see to a kid that can see with one pair of spectacles. So that's hypermetropia and myopia. Now we get to another condition in the eye, which is called astigmatism. Now, astigmatism has basically got nothing to do with the back of the eye. Hypermetropia and myopia was how far or near the retina was and had grown past its null point and so on. Astigmatism sits in the front of the eye. So it's the cornea. The cornea is supposed to be a perfect dome, half a soccer ball. It's supposed to be a perfect dome so that all the light gets bent to come to one little point on the retina. Okay? It bends the light so that everything comes to a perfect point on the retina. Now, when this dome is slightly cylindrical, in other words, it has more bending at the one place and less bending in another, in other words, more like half a rugby ball rather than half a soccer ball, then it's what we call astigmatism, and it has a certain angle at which the cylinder is. And for that, you need spectacle correction. Just a little footnote on the myopes, just to dispel an old wives' tale, is that we say, you hear often a patient will say, ever since my child started wearing glasses, the glasses just got fatter and fatter and fatter, and he should never have started wearing his glasses because the glasses are busy damaging his eyes. The glasses are damaging his eyes. So that is just simply 100% not true. What the glasses are doing, the glasses are adapting to the growth that is happening in the eye anyway. So the eye grows and we need to give him more minus because the eye has grown. The fact that we gave him a minus glasses didn't make his eye grow. The eye grows anyway. It's a bit like saying, ever since I let my child wear shoes, his feet started growing. And every year, I should never have let him wear shoes because his shoes are just, he started with a number 1 and he's already at a 12 shoe. Can you imagine? I should never have let him wear shoes because the shoes are making his feet grow. It's just not true. The growth happens anyway, and the glasses are there to keep him in focus. So they get fatter because the eye is getting longer. All right. So that never get caught up in all of that. The glasses are creating. Glasses can't affect an eye. Glasses in no way can change the shape of an eye. Glasses in no way can do anything to an eye. What glasses do is they bend the light to accommodate, or they bend the light to suit your specific needs in your eye. They bend the light before the time. So they bend the light, then it gets to your eye, which is now either astigmatic or long or short. And we can make an improvement in your vision by bending the light to suit your abnormal eye. It doesn't make the eye abnormal. So that's very interesting stuff. So right, so I think that has shone a light on some of the things. So in other words, very important, listen to your patients. Remember, vision is a subjective thing. Listen to your patient and be very attentive as to how they describe their vision subjectively, because that can give you a clue as to what is happening with them. Don't just go on and test their eyes and do all those things. Listen to them nicely. Right, so we've come to the end of this video. The next topic that we're going to tackle is a big one: diabetes. Diabetes. We're going to tackle that one in the next ones and give you some pointers as to how to either treat it or, most importantly, prevent such a devastating disease. Join me there.